Previously, we learned about the various morphological changes that occur during the process of necrosis, both appreciable under light microscope and electron microscope. We also learned about the characteristic features that are associated with necrosis. Now, we are going to learn about the various types of necrosis. So first things first, I'm gonna list all of them down. So these are the types of necrosis. Number one, coagulative necrosis and Jenker's degeneration. Jenker's degeneration is nothing but a special type of coagulative necrosis. Number two, liquefactive necrosis, which is also referred to as colliquative necrosis. Number three, caseous necrosis. It's called caseous necrosis because there is cheese-like necrosis. Number four, fat necrosis because there is fat involved. Number five, fibrinoid necrosis. Fibrinoid refers to fibrin-like. So in this necrosis, there is fibrin-like deposition. And number six, which is a clinical term, that is gangrene. So keep it in your mind. These are the necrosis that we are going to learn about. Number one, coagulative necrosis and Jenker's degeneration. Number two, liquefactive necrosis. Number three, fat necrosis. Number three, caseous necrosis. Number four, fat necrosis. Number five, fibrinoid necrosis. And number six, gangrene. First, we have coagulative necrosis. We are going to learn about all the types of necrosis under three headings. Number one, introduction. Number two, mechanism of action. And number three, morphological features, both gross and microscopic. First is coagulative necrosis. It is the most common type of necrosis and it makes complete sense. See, coagulative necrosis is as a result of ischemia. Ischemia is the most common cause of cell injury. So if most common cause of cell injury is causing necrosis, obviously that necrosis is going to be of most common type. That is why coagulative necrosis is the most common type of necrosis. Mechanism of action, I just said, it is due to ischemia of solid organs. Are there any other reasons? Yes, burns can lead to coagulative necrosis as well. Jenker's degeneration, I just said, Jenker's degeneration is a special type of coagulative necrosis. But out of all of these, the most common cause of coagulative necrosis is ischemia of, let me make this wiggly line properly. Okay, ischemia of solid organs. Solid organs like your liver, heart, and kidney. These are the three major solid organs that shows coagulative necrosis due to ischemia. But there are two solid organs, I repeat, solid organs, when they go through ischemia and eventually necrosis, the type of necrosis that take place is coagulative necrosis. But there are two exceptions. Two solid organs that when going through ischemia and necrosis does not go through coagulative necrosis are your brain and your pancreas. Remember, brain and pancreas, they do not go through coagulative necrosis upon ischemia. They go through something else, I'll say later. Next, morphological features. So I'm going to take two organs to show you gross and microscopy. Your kidney and the most common solid organ that goes through coagulative necrosis, that is your heart. Heart, most common. This is your kidney, this is your heart. In kidney, this pale wedge-shaped area you see, this is referred to as infarct. What is infarct? A new word. Infarct. Infarct is nothing but an area on solid organ. An area on solid organ that has gone through coagulative necrosis. An area of coagulative necrosis due to ischemia. Again, what is infarct? It is an area of coagulative necrosis on a solid organ that is due to ischemia. So if there is an infarct on kidney like this, that's renal infarct. If we are talking about an infarct on your heart, that's myocardial infarct. Simple. First, your renal infarct. So your renal infarct is wedge-shaped. It is pale And in terms of consistency, it's firm. Next, the most common organ, the heart. When a person goes through heart attack, the heart is going through myocardial infarction. The heart cells are dying. And here's a very interesting fact. Within 4 hours of death by myocardial infarction, a person has heart attack, he dies, you perform autopsy. Within 4 hours of death by myocardial infarction, grossly on heart, nothing is visible. In that case, you use a special stain. What do you use? You use a special stain called triphenyl tetrazolium chloride. Triphenyl tetrazolium chloride stains the normal heart brick red in color, but it does not stain the part of the heart that has infarct. It does not stain the infarct, so the infarct appears pale, or in other words, the infarct is TPTC negative. The reason behind it has to do something with LDH1, which I will not explain right now because that's under the CVS pathology. That I'll teach you under CVS pathology. For now, just remember, TPTC is a special stain that stains the normal heart brick red in color. It does not stain the infarct, so the infarct is TPTC negative. Okay. Now microscopy. This is the renal parenchyma. Here is normal renal parenchyma. That's the normal renal parenchyma. And this is the infarct within the renal parenchyma. In normal renal parenchyma, there is the glomerulus within the Bowman's capsule, and then there are lots of renal tubules. These glomerulus, Bowman's capsule, renal tubules, they are lined by cells. And these cells have two features. Number one, they have an outline, and number two, within the cell is the nucleus. Now, what type of change occur? Let's see in the infarct. In the infarct, these are all the renal tubules. What you can see is that the outline is still there. The outline is still preserved, but within the cell, the nucleus is disappeared. The cell looks completely empty. Khali. The cell looks empty. The renal tubules, they look empty as if there is nothing inside, like a ghost. Okay, another example. Here's your heart. In the heart, these are the cardiac cells. The outline, it is preserved, it is appreciated, but inside, there's nothing. It looks completely empty. The outline is preserved, but the cell appears empty. There's nothing inside. There is no nucleus inside. Let me show you another diagram. This diagram is something that you can draw in your exams. So this is the renal parenchyma. This is the normal renal parenchyma. This is the infarct within the renal parenchyma. Both of them have glomerulus, Bowman's capsule, renal tubule. Glomerulus, Bowman's capsule, renal tubule. But what's the difference? In normal parenchyma, the outline is preserved. The outline is preserved. Plus, within the cell, you can see the nucleus. You can see the outline, you can see the nucleus. But in case of an infarct, the outline is preserved. The outline is preserved. The outline is preserved. But inside, the nucleus is disappearing or not there. It will eventually disappear. See here. You can see any nucleus here. You can see the outline, but then can you see any nucleus here? No, you can't see any nucleus here. So the cells, they appear empty. They look empty, like a ghost. That is why they are referred to as ghost cell. Or what kind of appearance are they giving? They are giving tombstone appearance. Tombstone also, it has an outline, but inside it is completely empty. Like ghost also, look, there's an outline, but inside it is completely empty or translucent. So tombstone appearance. In a graveyard, what do you see? You see lots and lots of empty tombstones everywhere. So this also right here is kind of like a graveyard. There are lots and lots of ghost cell, empty looking cell on the background, lots and lots of tombstone appearing cells. Tombstone appearance. What I really want to say is that the most important thing that you need to remember is that in coagulative necrosis, the architecture is preserved. Architecture preserved. What is happening is that, see, this is the normal cell with the nucleus inside. When this goes through coagulative necrosis, the outline is still there, but inside it is completely empty. Due to the emptiness, it is called ghost cell or tombstone appearance. And due to the preservation of architecture, I'm emphasizing on the fact that due to the preservation of outline, I'm emphasizing on the fact that architecture is preserved. I'm repeating again and again because it is only the coagulative necrosis where the architecture or the outline is preserved. After that, everything becomes tahas nahas. Okay, Jenker's degeneration. Jenker's degeneration, also called waxy hyaline degeneration, is nothing but a spatial type of coagulative necrosis. Mechanism of action. Spatial because it is seen during typhoid and it is seen in skeletal muscle, more specifically your abdominal muscle, rectus abdominis. Rectus abdominis and diaphragmatic muscle. Diaphragmatic muscle. See, your second name will give you information about gross and microscopy. Grossly, it looks waxy, and microscopically, it appears hyaline-like appearance. See, waxy hyaline degeneration, hyaline appearance and waxy. What do I mean by hyaline appearance? Let's look at the microscopy. So, I said that Jenker's degeneration is seen in skeletal muscle. Skeletal muscle contains cylindrical muscle fibers arranged in bundles with striations in them. But when Jenker's degeneration or the coagulative necrosis of this skeletal muscle takes place, these striations are lost. These striations are lost. See, are there any striations visible in this muscle fiber? No. So it seems as if hyaline has gone and deposited there. So hyaline-like appearance. Okay, are you having fun? I am having. So let's continue. Second is liquefactive necrosis. It is also known as colliquative necrosis. Mechanism of action. See, previously I said that ischemia of solid organs leads to coagulative necrosis. But then I said there are two organs that does not show coagulative necrosis when going through ischemia. They are brain and pancreas. They show liquefactive necrosis. So ischemia of two solid organs. What? Ischemia of a brain and ischemia of pancreas. They show liquefactive necrosis. Now, there is no specific reason behind it, but some places it says it is due to high amount of hydrolytic enzyme in them. So due to high amount of hydrolytic enzyme, they digest everything and make everything liquid. Hydrolytic enzyme. Second, do you know what a pus is? Pus is like a battleground. It's nothing but an area that is going through liquefactive necrosis. Pus is where you see necrosis going, you see alive, dead, and dying various types of cells, like your normal parenchyma cell, your WBCs, the bacteria causing the necrosis, the cell debris and everything. It's like a pool of dead, alive and dying cells. So this pus that I'm talking about is also an area of liquefactive necrosis. So when there is pyogenic infection is nothing but an infection that leads to the formation of pus. Again, let's make it more wavy. Okay, now there is pus formation. And when pus is localized in a specific area, that is abscess. Localized pus is abscess. This is where you can see liquefactive necrosis as well. Okay, let's look at the gross. In the brain, this whole area has gone through liquefactive necrosis. What does it look like? It looks semi-liquid. Semi-liquid. In coagulative necrosis, I said the architecture is preserved, but now there is no architecture to be preserved. Everything becomes the hasnas, everything that gets destroyed, everything becomes liquidy. So see here, liquefactive necrosis. This is the normal parenchyma, this is liquefactive necrosis. One thing I missed, I have said this in the previous video, necrosis is always accompanied by inflammation. So in microscopy, you draw the normal parenchyma, you draw the necrosis or the infarct. In coagulative necrosis, you have the infarct and obviously the inflammatory cells because there is inflammation. In case of liquefactive necrosis as well, you draw the normal parenchyma, you draw the necrosis, and then here is granulation tissue. Granulation tissue is formed during the process of healing. So this is basically showing the process of healing. You could also draw inflammatory cells, because there is necrosis, there will be inflammation. Next is caseous necrosis. Introduction. Before introduction, let me give you the mechanism of action. I said that whenever there is pyogenic infection, there is formation of pus. And pus is nothing but an area where liquefactive necrosis is in. But not always. In case of these pyogenic infections, at the area of pus, liquefactive necrosis is not the only thing that is taking place. In case of tuberculosis, in case of syphilis, there is pyogenic infection. In case of coccidiomycosis, in case of histoplasmosis, there is pyogenic infection. But in this case, you have coagulative necrosis taking place as well as liquefactive necrosis taking place. You have both taking place. Coagulative necrosis is more than liquefactive necrosis, leading to cheese-like necrosis, Swiss cheese-like necrosis. This is referred to as caseous necrosis. Now the question is, why is it that here pyogenic infection led to the formation of pus with liquefactive necrosis, but here pyogenic infection due to specific pyogens, 4 of them, remember, tuberculosis, syphilis, fungal infection like coccidiomycosis and histoplasmosis. Why did they lead to caseous necrosis? Now this is because of the association of high level of lipid in cell wall. That is why. So remember, pyogenic infection leads to formation of pus that has liquefactive necrosis, except in case of tuberculosis, syphilis, coccidiomycosis, and histoplasmosis, where caseous necrosis is seen. So let's take example of tuberculosis. Okay, in tuberculosis, you have pulmonary tuberculosis, so there's the lung. This right here is where the caseous necrosis is going on, and it looks cheese-like. Microscopically, there is formation of caseous granuloma. What is this? Again, do we have a necrosis? Yes. Is necrosis associated with inflammation? Yes. So here also inflammation is taking place. But here chronic inflammation takes place. And a specific type of chronic inflammation where there is formation of granuloma is referred to as chronic granulomatous inflammation. In this case also, there is formation of granuloma in case of inflammation. So this is chronic granulomatous inflammation. What is granuloma? So in granuloma, in the middle, there is necrosis. In this case, caseous necrosis is going on. Since we are taking example of TB, you can see Mycobacterium tuberculosis as well. In green, these are Mycobacterium. In yellow, that is caseous necrosis. Now this area of caseous necrosis and Mycobacterium tuberculosis pus, it is surrounded by epithelioid cells. Some of these epithelioid cells, they fuse to make multinucleated giant cell. Outside that are inflammatory cells, even more inflammatory cells. All of these are inflammatory cells. Inner layer of inflammatory cells are the epithelioid cells that fuse to make up the giant cell, multinucleated giant cell. Outside that are another layer of inflammatory cells called lymphocytes. The round cells are the lymphocytes. And then outside there are the healing cells, fibroblasts. They make up the fibers. So what is there from inside to outside? There's necrosis. In this case, there is caseous necrosis. And in this case, there are bacteria also, because it is due to Mycobacterium tuberculosis. Outside that is the epithelioid cells. Some of these epithelioid cells, they fuse to form giant cells. Outside that is a layer of lymphocytes. And outside that is a layer of fibroblast. This whole thing right here is referred to as a granuloma. Since in this granuloma, the necrosis that is taking place is caseous necrosis, so we call it caseous granuloma. So when is caseous granuloma formed? When is granuloma formed? In granuloma formed in case of chronic granulomatous inflammation. Is this a necrosis? Yes. Is it associated with inflammation? Yes. Here, which inflammation is taking place? Chronic inflammation. Which type of chronic inflammation? Chronic granulomatous inflammation. So is there granuloma gonna form? Yes. What type of granuloma? Caseous. Why? Because in this granuloma, the necrosis going on is caseous necrosis. Okay, even after this you are confused, no worries, because this is a topic of chronic inflammation. I'll tell you about granuloma there. So same thing in microscopy, just draw caseous granuloma. There is caseous necrosis in the middle, surrounded by the granuloma, the inflammatory cells, the epithelioid cells. These are epithelioid cells. Some of these epithelioid cells, they fuse to form multinucleated giant cells, and then these are the lymphocytes. Okay, we are done with caseous necrosis. Next, fat necrosis. It is seen in structures with high amount of fat, like breast, omentum, and peripancreas. Peripancreas, not pancreas, peripancreas. Mechanism of action: breast, omentum / peripancreas. Okay, so these structures, they contain a large amount of fat in them. Now, due to any reason, which I'll tell later, let's say due to various reason, the fat present in these organs, in these structures, they get broken down. Fat breakdown. What happens when fat gets broken down? Fat gets broken down into fatty acid and glycerol. What happens when calcium combines with fatty acid? It forms calcium salt of fatty acid. What is that called? That's a soap. That's your soap. Have you not learned the process of saponification in chemistry? Saponification. What happens in saponification? Sodium potassium salt of large chain acid is formed. Large chain acid like fatty acid. Sodium potassium salt of fatty acid is soap. The formation of sodium potassium salt of fatty acid is saponification. Here, instead of sodium potassium, there is calcium. So calcium salt of fatty acid, soap formation, saponification, whatever, there is saponification. As a result, grossly, it appears chalky white. See these areas, chalky white areas. These are your areas of fat necrosis, where the process of saponification has taken place due to the addition of calcium to broken down fat, that is fatty acid. Now, what are the reasons that fat gets broken down in breast? Trauma. Let's say you have a female boxer who continuously gets traumatized in breast region, continuous punch to the breast region. As a result, fat gets broken down. Let's say this another person has acute pancreatitis. Due to acute pancreatitis, there is increased level of lipase enzyme. Lipase goes and breaks down fat in omentum and peripancreas. Microscopy. Since you have cells filled with lipid, obviously it is going to appear cloudy. Since it's a necrosis, it is associated with inflammation. So you are going to find inflammatory cell. So draw cloudy appearance with inflammatory cells in exam. Next is fibrinoid necrosis. It is associated with fibrin-like deposition. Fibrinoid means fibrin-like. Mechanism of action: there is deposition of antigen-antibody complex in CVS. That is your blood vessel and your heart. In what cases? In blood vessel, in case of polyarteritis nodosa, in case of malignant hypertension, and in case of systemic lupus erythematosus. In case of heart, in case of rheumatic heart disease, at areas where there is formation of Ascoff bodies. It's completely natural if you can't remember these terminologies right now, because you are going to learn about polyarteritis nodosa and malignant hypertension under the topic of blood vessels in CVS pathology, and rheumatic heart disease ASCOF bodies under the topic of heart in CVS, and SLE later on in general. But just remember that there is antigen antibody deposition in blood vessel and heart in fibrinoid necrosis. What is this? This is the blood vessel. Here is the lumen of the blood vessel, inside which are RBCs, and in the wall of the blood vessel, fibrinoid necrosis has taken place, which shows fibrin-like deposition. What is it? It's a necrosis. So obviously there is going to be inflammation. So you are going to see inflammatory cells. See, same thing here. There's the lumen with red blood cells, and there is fibrin-like deposition here, and then there are inflammatory cells. Boom, done. Next, gangrene. Before getting into gangrene, one last revision of these various types of necrosis, okay? Only the important points. See, coagulative necrosis, remember, is due to ischemia. Ischemia is the most common reason behind cell injury. So obviously, coagulative necrosis is the most common type of necrosis seen. Now, careful, listen. Ischemia of solid organs causes coagulative necrosis, except brain and pancreas. Ischemia of brain and pancreas causes liquefactive necrosis. Another, pyogenic infection causes liquefactive necrosis in pus, except TB, syphilis, coccidiomycosis, and histoplasmosis. These show caseous necrosis. Fat necrosis is seen in organs with large amount of fat. Fibrinoid necrosis is seen in blood vessel and heart where there is fibrin-like deposition. Boom. Remember this one. Okay? Coagulative necrosis due to ischemia of solid organs except brain and pancreas. So take that and put it in liquefactive necrosis. So in liquefactive necrosis, it is due to ischemia of brain and pancreas, plus due to pyogenic infection leading to formation of pus, except TB, syphilis, coccidiomycosis, and histoplasmosis. Now take that and put it into caseous necrosis. So in caseous necrosis, it is due to pyogenic infection by those that does not cause liquefactive necrosis, that is TB, syphilis, coccidiomycosis, and histoplasmosis. Fat necrosis in fat rich organ, fibrinoid necrosis, there is deposition of fibrin and there is deposition of antigen antibody complex in blood vessel and heart. Okay, now let's talk about the clinical term, that is gangrene. See, gangrene is a necrosis plus putrefaction. Putrefaction means decaying, सड़ना. ये पेड़ को देखो भाई, सड़ गया है, नेक्रोसिस होकर पूरा सड़ गया है, काला हो गया है. So that is gangrene, blackening and decaying of the organ with necrosis. There are three types of gangrene: dry gangrene, wet gangrene, and gas gangrene. Very easy. Listen, dry gangrene, there is coagulative necrosis. Wet gangrene, there is liquefactive necrosis, plus super added infection. Means there is infection as well. From above, there is infection as well. In dry gangrene, see, is the outline well demarcated? Yes. You can easily separate. You can look at the outline. So there is outline is demarcated. In wet gangrene, can you see the outline? No. It kind of overlaps over one another. So outline is not visible. So there is no outline. Simple, that's it. That's dry gangrene and wet gangrene. Dry gangrene, coagulative necrosis. Wet gangrene, liquefactive necrosis along with infection. Dry gangrene, outline is demarcated. Wet gangrene, outline is not demarcated. What is gas gangrene? Gas gangrene is nothing but a special type of wet gangrene. That means, yes, gas gangrene also has liquefactive necrosis. Yes, gas gangrene also has superadded infection. So it's copy paste. But the superadded infection in gas gangrene is special. It is due to infection by gas producing microorganism. And the most famous one being Clostridium. And within Clostridium, the most famous one is Clostridium perfringens. That is why due to the production of gas, there is formation of bubbles, as you can see here. This is gas gangrene. And with that, we are done with necrosis, the various types of necrosis. I hope you enjoyed this video, and yes, all the slides are gonna be available for free in my Telegram group, for which the link will be provided in the comment section or description. It can be anywhere. See you again.